Welcome back to The Explainer. Today, we're diving into exactly how you, the medical biller and coder, really act as a clinical detective. I mean, think about it. Just one single missing detail can literally cost a facility thousands of dollars or totally skew a patient's health profile. You guys are the crucial bridge between patient care and accurate revenue. Your attention to detail literally impacts the whole healthcare system. So let's just get right into it. Here's our quick roadmap for today's explainer. We're going to cover the power of documentation, physician queries, uncovering missing procedures, DRGs and RVUs, clinical documentation improvement, and finally, ACOs and quality metrics. All right, section 1, the power of documentation. This is absolutely the foundation of coding. You know, when you're reviewing a medical record, you are doing way more than just reading. You're actually verifying a compliant audit trail. Step 1, you verify the patient details. Step 2, you ensure all the billable codes are actually listed in the documentation. Step 3 is confirming medical necessity, making sure the paperwork actually supports the treatment. And Step 4, checking for absent procedures. It's super important because any misstep here totally disrupts the revenue cycle and compliance. Because the golden rule here is simple. Documentation dictates reimbursement. Honestly, it doesn't matter how obvious a procedure might seem in context. If the doctor didn't explicitly write it down in their notes, legally and financially speaking, it literally did not happen. You are completely bound by the written word. Moving on to Section 2, conducting physician queries to set the record straight. So, this brings us to a really crucial question that every coder faces. When exactly should you ask the doctor for clarification? And, more importantly, how do you do it in a totally compliant way? Well, our source material brings up this really fascinating dynamic that happens in the real world. It notes that if you work with a specific doctor for a while, you get so used to their methods that you almost get, quote-unquote, in the doctor's mind whenever you read their documents. You start anticipating what they're going to do. You know that if they do procedure A, they almost always do procedure B. You basically get inside their head. But, and this is a massive caution right here, you absolutely cannot code based on assumptions. And when you do reach out to them, you cannot lead the witness. Your queries have to be compliant, non-leading requests for clarification. You are strictly prohibited from sending what we call leading queries that improperly suggest specific, high reimbursement diagnoses just because you know the doctor's habits. Bottom line, if it isn't written down, you've got to hit pause and initiate a compliant query. Okay. Section 3, uncovering missing procedures. This is where the coder truly acts as a detective. So, what are the two main culprits you're actually hunting for? It comes down to implied procedures versus missing procedures. An implied procedure might just be sitting up there in the header, but completely vanishes in the body of the text. And a missing procedure? Well, that's when a diagnosis is clearly stated, but there is mysteriously no treatment mentioned to match it. Both of these situations require you to go back to the source for a non-leading clarification so you avoid undercoding. Sure, software might catch an unbundled code, but it can't always spot what simply isn't there, right? That is exactly why your role is so critical. You are the final line of defense against leaving money on the table due to incomplete records. Your detective work ensures that every single provided service is accurately captured and properly verified. Let's jump to Section 4, DRGs and RVUs explained. This is all about translating care into compensation. First, let's look at DRGs, or diagnosis-related groups, specifically in the hospital setting. The massive takeaway here is severity. DRGs rely entirely on accurate documentation of the patient's severity of illness, or SOI, and their risk of mortality, or ROM. Basically, the higher the documented risk, the higher the legitimate compensation to cover the immense resources involved in that patient's care. Now, for individual outpatient procedures, that's where the RVU, or relative value unit, comes in. Systems like Medicare use RVUs to assign a specific, exact monetary value to every single CPT code. It's essentially the foundation that determines a service's overall cost and its base reimbursement rate. So how is an RVU actually calculated? It's a combination of 3 distinct parts. First up, you have the physician's time, training, and expertise. Second, you factor in operational costs. Things like rent, equipment, and paying employees. And third, variable malpractice or liability costs. Which totally makes sense, right? It's why an obstetrician's RVU inherently differs from a primary care provider's. You combine these 3 parts, multiply them by a regional or geographic conversion factor, and boom, you get your final payment. All right, Section 5, clinical documentation improvement, tracking all this data. CDI, or Clinical Documentation Improvement, is that crucial software bridge between clinical care and revenue cycle integrity. Because modern coding systems like ICD-10 are just so insanely hyperspecific, this software makes translating clinical conditions into accurately coded data a lot easier. But remember, it's only as good as the data you feed it. It absolutely relies on your precise documentation and your meticulous verification to even function properly. And the impact of this CDI data goes way, way beyond just a single bill. It dictates hospital quality scores, mortality and complication rates, and reimbursement under value-based purchasing programs. The accuracy of your coding feeds directly into public health tracking and global illness monitoring. It is a massive deal. Which leads us perfectly into Section 6, ACOs and quality metrics. Let's look at the big picture. This brings us to accountable care organizations, or ACOs. As an industry, we are really moving away from those traditional fee-for-service models and moving towards value-based risk adjustment models. ACOs link provider payments directly to patient quality indicators. And the funding is often determined by capturing a patient's chronic disease burden annually through HCCs, or hierarchical condition categories. Because of this shift, ACOs are financially rewarded for providing savings while simultaneously enhancing patient care. But here's the catch. To actually prove those savings, they need incredibly accurate data on how sick their patients actually are. By accurately documenting those HCCs and precise severity, you are the one allowing these organizations to prove they are delivering excellent, cost-effective outcomes. Ultimately, your meticulous coding bridges that massive gap between individual patient care, revenue integrity for the facility, and macro-level global health metrics. Your work as a clinical detective literally ensures the entire healthcare system functions fairly, accurately, and efficiently. So the next time you review a chart, I want you to ask yourself what missing detail might completely change this patient's story. Please like, share, and subscribe to Decode Healthcare with Harshal.